This lecture is going to take us through the hypersensitivity disorders and autoimmune disorders, and specifically AIDS. It's going to be very important as we move into the first PULSE project in particular. This first slide is simply a review of the immunoglobulins, hopefully something that you've covered in A&P. And if you took A&P here, or A&P2 in particular here, this picture should look familiar. It's straight from the A&P2 book. This lists the various classes of immunoglobulins and their functions. I don't ask you to have any specific questions from this slide. However, I do expect that you understand that the functions of these immunoglobulins as we move into these hypersensitivity disorders, because I refer to them. So although I'm not going to have any kind of matching or specific questions about this, as we get into hypersensitivity disorders and the 4 types, there are different immunoglobulins involved with each. So in terms of hypersensitivity disorders, what we're talking about is an inappropriate immune response. So something has caused the immune system to overreact, and we can put those overreactions into 4 basic types depending upon their responses. So the book goes into lots and lots of detail about each of these. What you see in this lecture on these hypersensitivity disorders is what I'm going to be holding you responsible for. So the first type, type 1 hypersensitivity disorder, is what we often refer to as the allergic reactions. Begins very rapidly, often within just moments of contact with something. Does depend upon how it enters the body as to whether or not that will be as immediate or not a reaction. So you can have overarching body reactions, or what we refer to as anaphylactic actions, so they can be severe, life-threatening. The CD4 plus, the T helper cells, mast cells, basophils, and the IgE antibodies are involved in this response. And then we have examples of that. So hay fever, clearly not life-threatening usually, or anaphylactic. However, food allergies can be. So certain food allergies, peanut allergies, things of that nature fit in here and can lead to very systemic and severe reactions very quickly. Asthma is a type 1 hypersensitivity, although can lead to severe reactions and asthmatic attacks, is not always life-threatening. The formation of hives or atopic dermatitis, they're really kind of the same thing. These are all things that are type 1 hypersensitivity. Type 2 are referred to as antibody-mediated. The IgGs or IgMs are involved here, trying to attack the foreign antigens. These may be things that are already on our cell surfaces, or they may be absorbed or incorporated into the cell membrane due to some action within the body. So this is really where we put in, again, this is your wrong blood type. So the antigens are already there, the markers are already on the cell surfaces, and we react to the foreign substance that's been introduced in. So if I'm given the wrong blood type, if I'm an A positive and I'm given an A negative, that's the RH disease issues, the positive and negative, and certain drug interactions. If you were to be given medication that you have an allergic reaction to, the drug problems go here, wrong, not type 1. It's a little bit different. Remember, in type 1, we have certain food allergies. It's a little different interaction than what you see with the wrong medications being given, or you're allergic to penicillin or what have you. That's an antibody-mediated response. Type 3, immune complex mediated. This is an antigen that's not attached to the cells plus the antibody, so it's a circulating complex. That gets a little more complicated. So in the previous one, we were dealing with markers already on our blood cells responding to something foreign being brought into the body. These are antigens not attached to cells and antibodies, so they join up in the blood, in the tissues, and they deposit at various levels, and we get complement involved here. So IgMs, IgGs, and sometimes IgAs are all involved in this inflammatory response. So this is what we see more in lupus, what we see we refer to as serum sickness, or this is usually what you get with reactions to certain antibiotics. The arthritis reaction, some kind of damage to the local tissue, then we start to see necroses forming. So these are some examples of what you'll see in a immune complex mediated response. So this involves the use of antibodies. little less common, but again, autoimmune vasculitis, by the way, refers to inflammation of the blood vessels due to some sort of autoimmune response. So that's where lupus fits in there, and even the glomerular nephritis also fits into that one as well. Not nearly as commonly heard a disorder, but this is a problem with the glomerulus in the kidneys. And then type 4 cell-mediated hypersensitivity. This is going to involve T cells specifically attacking the antigen. It's a direct kill kind of a damage. The most common one would be the forms of hepatitis, in which we see that involved there. It's also what you see if you have the TB test. Certain inhaled antigens. So this one's a little bit more profound. I always think that the type 4 cell-mediated hypersensitivity actually seems a little bit like the type 1, except if you look back at what type 1 is doing with the immediate hypersensitivity, we do have T cell involved, and we really don't have the killing going on to the same level. It's more of a mast cell and an engulfing. But in type 4, this is where the cytotoxic T's, the CD8s, are directly involved in the response. So it does involve what seems similar to allergic reactions, particularly the hypersensitivity things from inhaled antigens and so forth. It's more internal, it's more profound effect. So those are your 4 hypersensitivities. Again, they're in the chapters. I've pulled just little pieces of summary from each one so that you could see the difference. Be sure that you're aware of the types of cells or immunoglobulins that are involved in each and an example of each. All right, then we go into HIV. The HIV versus AIDS. HIV is the name for the virus. The virus is what causes AIDS, so it's the manifestations of the infection. So you do not have what we refer to as full-blown AIDS until you get pretty far along in the progression of the disease, but the virus is the cause. So just a little bit of detail from the CDC, I always like to kind of throw in, and they didn't have anything more updated yet than 2010 in the sources that I looked, but taking a look at the populations of new HIV cases, again, almost 5 years, or probably a full 5 years ago now, in terms of the data collection. But in case you were thinking HIV was going away, that absolutely is not the case. There are new cases every year coming forward, and taking a look at who's being infected. That it is no longer something that we just put to one small group of people. It is affecting our population across the board. Transmission of HIV, sexual contact, body fluids, blood fluids. It can be passed perinatal as mother to child. It's important to understand that there's this process referred to as seroconversion. Seroconversion refers to the process by which we start making the antibodies in order to attack. So there is a window period of 1 to 6 months after the person has been exposed where the antibody is not fully forming yet in the body, but you absolutely can transmit. We are able to test for it during this time, so it's very easy now. We have very sensitive testing to identify the presence of HIV, but the full seroconversion and formation of antibodies does not happen immediately upon contact with the virus. Occupational risk, I just mentioned here, that risk is not as high as I think people may have at one time thought. If you're working with HIV patients, do you have a high risk of contracting the disease? And you absolutely do not. Universal blood and body fluid precautions are what you will take with any patient, not just an HIV patient. You don't want to come in contact with the bloods and products and fluid products from any patient, regardless of their infection status. So you wear gloves and gowns and so forth, masks as necessary. So good safety precautions that are done with every patient will in fact protect someone against HIV as well when you are treating these patients. So you obviously avoid all needle sticks, and there are steps, what is referred to as universal blood and body fluid precautions that are taken in all cases. So I just mentioned that to note that there is not a great risk of transmission for healthcare providers. So what is the pathophysiology? What exactly do does HIV do? Well, its primary attack is the CD4 helper T cells, but it also attacks macrophages and the dendritic cells. And dendritic cells act as antigen-presenting cells. Hopefully you know that from AMP2 as well. Antigen-presenting cells are cells that attach to foreign substances and prepare them for killing so that the T cells or the natural killer cells can come and destroy them. So they're definitely a huge helper in that process. They themselves do not provide killing or engulfing, but they help prepare them for that. The HIV virus is an RNA retrovirus. There are two types that you see within the United States. Two types that you see, with one more common in the U.S., the HIV-1, HIV-2 in Western and Africa. The manifestations are similar, and in fact, there's some mutations that are now giving you subsets for some of these as well. So, what's inside the virus itself? It contains 2 copies of the RNA, a capsid protein that targets the target for the antibodies that we look at to screen, and then 3 important viral enzymes, protease, reverse transcriptase, and integrase. And so in the process of how this virus actually, before I go forward, how this virus actually attaches and functions, the HIV attaches primarily to the T helper cell. Again, it can be others, but attaches to the cell, internalizes into the cell. So it literally uncoats itself and enters into the cell. Once inside, it uses the reverse transcriptase to create DNA, and then the new DNA enters the nucleus, and it enters that nucleus using the enzyme integrase. So it goes inside the cell, uses reverse transcriptase to go from RNA to DNA. Integrase allows it to go inside the nucleus, and then inside the nucleus, we have transcription of the viral DNA to form viral messenger RNA, and now we can make new viruses because we've now taken over the DNA we've got the viral DNA going into the nucleus, taking over the DNA of that cell, making messenger RNA. Now it can make a copy of itself, and so it's now ready to go out and make new viruses. At that point, the messenger RNA goes out and forms a polyprotein at the ribosome, and then the protease is an enzyme that cleaves off the protein into the parts that make up the new viruses. So the virus comes with 3 enzymes to do its work, and all it needs to do is get into our nucleus, take over the cell, and really destroys the cell. As it leaves the cell, having made multiple copies from those proteins that the protease chopped up and said, here's my new pieces of proteins, it then leaves the T cell, macrophage, or dendritic cell, and having left it destroyed, it is now dead, and we have new copies of the virus circulating around. So that's the process, that's the patho and cellular level of what's going on there. Don't usually ask too much from an exam purposes and you redoing that whole series, but understanding that these enzymes are what exist in order to allow the replication of the viral DNA to become a viral RNA in order to spread the virus throughout the body. That the HIV comes well prepared, takes over the nucleus, and destroys the cell at the end, of making new copies of itself, and not a single copy, but multiple copies of itself. So that's the patho from a cellular level, of what's happening with HIV. So how do we classify HIV? And this is the standards. And you know what? Now that I'm looking at this slide, I don't have the textbook in front of me. The chart is still 16-3, but I think the page number has changed in the new edition of the book, and I failed to upgrade this on my slide, and I'm just now seeing it as I'm talking to you. So be sure that you take a look in the book. There are these conditions, AIDS-defining conditions are in the book. I'm pretty sure it's still 16-3, but check the page number. I don't believe that's accurate. However, the table is still very accurate, the CDC's table for how they classify HIV infections. So it's 2 parts. If your CD4 cell count is 500 or greater, you're at a level 1. If you are asymptomatic, acute HIV or PGL, basically saying you don't have any real symptoms, nothing is really showing up at this point. You may have had some illness initially, but you've now gotten to that point that you're asymptomatic. You have an A. So 500 or greater, basically asymptomatic, you are at an A1. If you are 500 or greater, but you have symptomatic conditions, so you're not asymptomatic, but you don't have the AIDS indicator conditions, then you're at a B1. If you have 500 or greater, but you have AIDS indicator conditions, you're at a C1. That's probably fairly rare. If you're having these defining conditions, you probably have a much lower CD4 or T cell count. And so if you're between 200 and 499, you're at a level 2, and you're below 200, you're at a level 3. So hopefully this table, this is copied straight from the CDC. This is how they lay it out. So this is the classifications. Be sure you can understand and know these classifications. The phases of the infection. Phase 1 is the primary infection. There can be no symptoms. There can be flu-like symptoms in enlarged lymph nodes, kind of a fever, and you feel kind of yucky. And then seroconversion takes place, and you start to produce antibodies to try and fight this infection. So usually within 4 weeks of exposure, there may be this or there may be nothing. But the seroconversion is beginning, hopefully, in many cases around that time, although it can take longer than 4 weeks for seroconversion to initiate. The second phase is a latency period, pretty much asymptomatic. If there's treatment, we're seeing that you can last 10 or more years in the latency period. If you do not have treatment, however, that latency period is nowhere near this long. And then phase 3, overt AIDS, is where your CD count starts to drop below the 200, or you have an AIDS-defining condition. And without any treatment, an AIDS patient will be dead within 2 to 3 years. And really that's 2 to 3 years from phase 1 all the way through phase 3. Treatments, we're seeing people live 20 plus years now. So what are those AIDS-defining diseases or opportunistic infections? These are some of the big ones. These are the ones I would test you on in terms of your project that you'll be working on. Recognize there are many others to choose from. But I gave you some examples. These are from that table and mentioned in the book. But some respiratory diseases, pneumocystic cardiac pneumonia, Mycobacterium tuberculosis, that's TB. So TB is ranked very high in those that suffer from HIV or full-blown AIDS. There are GI diseases that are common that occur. This is where the immune system can no longer keep these things at bay and they start taking over. AIDS dementia complex is one I always like to specifically mention. All of these other conditions, the malignancies, the wasting syndrome, they're all linked to failure of your immune system. But AIDS dementia complex is caused by the virus itself. It invades the cells of the brain, and when it does that, it destroys neurons within the brain. This is different than the other the other infections that can occur. And this one, the virus itself causes it. In the others, of course, the virus is involved, but it's a failure of the immune system as to why these other conditions occur. So, and note, for instance, this is damage to tissue. Inflammation is certainly part of what you see with HIV, and fever is absolutely involved in this. That takes you to the end of the content on the immune system. Be sure you're reading through the content in the chapter, however, on this, and I hate to be on a black screen, so I'll go back to this. Just reminding you, as you're going to be working on this project for HIV and with the sociology component overlying it, that you have a good understanding of what is happening with the disease, the causes for the disease, the risk factors involved in it, the phases of it. So if you're going to be creating a project that helps get the message out to people, you want to be sure that you're making that your information on how the disease can occur, how the disease progresses, how the disease is defined between HIV and AIDS is important for you to include in your project.